అపాచీలు అంటే ఎవరు శ్రీకాంత్?
అంటే బేసిక్గా ఇది స్టోరీ ఆఫ్ లైక్ అమెరికా మెక్సికో వార్ రిలేటెడ్ సార్, బాగా 1800s టైమ్ అంత రెవల్యూషన్ అంతాను. సో అక్కడ టెక్
అపాచీలు అంటే వాళ్ళేనా?
అక్కడ అదే సార్, అడవి జాతి మనుషులు సార్. అంటే తర్వాత వీళ్ళనే అదే రెడ్ ఇండియన్స్ అంటారు అక్కడ. అపాచీలు రెడ్ ఇండియన్స్ సినానిమ్స్ సార్. అంటే వాళ్ళందరూ అక్కడ యాక్చువల్లీ యుఎస్ ని అపోజ్ చేసే వాళ్ళు సార్, ఫోర్స్ అంతా అక్కడ కూడా.
మా క్లాస్మేట్ ఒక అమ్మాయి
వీళ్ళు అలాగా అడవుల్ని ఎంకరేజ్ చేద్దాం అనుకుంటే వాళ్ళు ఫైట్ చేస్తూ అమెరికన్స్ ని ఫైట్ చేస్తారు.
ఇజ్రాయెల్ ఎక్కడికి వెళ్తుంది? ఇజ్రాయెల్ ఎక్కడికి వెళ్తుంది ఇప్పుడు?
ఏమొస్తుంది
గాజాను తీసేసుకుంటుందా?
అంతే, సోషల్ అంట్రెస్ట్ సార్
మొత్తం. అది ఇక్కడ కూడా అలాగే మొదలవుద్దాం భయం వేస్తుంది.
ఇంకా అంతే సార్.
ఇండియాలో కూడా ఐ థింక్ వీఆర్ ఆలోచిస్తే వీఆర్ ఇన్ వెరీ వెరీ సేఫెస్ట్ ప్లేస్ అనిపిస్తుంది.
అంతే సార్,
సో లక్కీ అనిపిస్తుంది.
రెవల్యూషన్స్ అవన్నీ అండ్ వార్స్ అయ్యే ప్లేసుల్లోని లైక్ ఏ రోజు ఎలా ఉంటుంది అన్నది కూడా తెలియదు కదా సార్. ఆ మెక్సికో క్యూబాలో
చాలా బాగుంటాయి కానీ
లైక్ అంటే మల్టీ మిలియనర్స్ కూడా కంప్లీట్ గా ఆస్తులన్నీ వదిలేసి దేశం వదిలేసిన సందర్భాలు కూడా చాలా ఉన్నాయి సార్.
క్లాస్మేట్ ఒకడు ఉండేవాడు, ఇరాన్ లో వార్ వచ్చినప్పుడు వచ్చాడు అక్కడికి మణిపాల్కి చదువుకోవడానికి. వాడు చెప్పేవాడు ద లైఫ్ ఈస్ టోటలీ డిఫరెంట్. అంటే మనం ఇక్కడ కూర్చొని బుక్కులు చదువుతాం, క్లాసులు చెప్పండి కానీ మన నిజంగా వన్స్ సంబడి ఫేసెస్ దట్ లైఫ్ ఈస్ సంథింగ్ టోటలీ డిఫరెంట్. కొన్ని వీడియోలు చూస్తుంటే గగురు పొడుస్తుంది ఒళ్ళు, ద వే ద కిల్లింగ్ చూస్తుంటే రియల్లీ హారిబుల్.
ఇంక ల్యాండ్ వార్ స్టార్ట్ చేస్తాను అన్నారు కదా సార్, ఇంకా వర్స్ అయిపోద్ది కండిషన్.
ఇది
ఇజ్రాయెల్ టెరిటరీలో అదే బోర్డర్ లో ఉన్న వాళ్ళ సిటీస్ అన్ని ఎవాక్యుయేట్ చేస్తున్నాయి సార్. ల్యాండ్ వార్ ఇంకా స్టార్ట్ చేసే ప్లాన్స్ లో ఉన్నారు. ఇంకా వర్స్ట్ గా ఉంటుంది సిచ్యువేషన్.
ఆల్రెడీ చేసినట్టున్నారుగా.
అదే అంటే నిన్న పేపర్ లో వచ్చింది సార్, ఎవాక్యుయేట్ చేస్తున్నారు.
ఎలక్ట్రిసిటీ అన్ని ఆపేసారని. అక్కడ గజాకి వాటర్ ఎలక్ట్రిసిటీ అన్ని ఆపేసారు అనేది వచ్చింది.
వాటర్ ఎలక్ట్రిసిటీ అన్ని ఆపేసారు. Around 11 members should start.
Okay. Thank you.
Yeah.
Okay, today our Srikanth, multifaceted, multi-talented, the boss of ABC, and who is an intensivist and anesthesiologist and pain specialist and a techie guy. Dr. Bachu Srikanth is going to start a class on role of Algesimeters in anesthesia practice. Thank you.
Thank you, sir. Thank you so much. So, first of all, before starting the class, I would like to, as people in the group are there, so one of my dear friend, Kiran from GMR Care, he came all the way from Rajam just to attend my talk. So I would like to express my thanks first to that. And this is the topic given to me by the organizers of state conference. So to tell about how whenever we face a disaster event, we tell the sequence of events. So
one small question, Srikanth.
Sir.
Did they decide this topic or you told them that this topic is good? Because normally they do not come with the same topic, no?
Actually, this is the like Avik Jayan sir ki idi baga favorite answer. He wants somebody to speak about it. సో అకాడమిక్ మీటింగ్ అయినప్పుడు కూడా he was like నేను వెనకాతలు ఎక్కడ ఉన్నాను, he was talking to someone else and saying like రొటీన్ టాపిక్స్ ఎప్పుడు ఉండేవేనండి మేనేజ్మెంట్స్ అవన్నీ. See the topics like Algesimeters, those take the conference to a next level అని చెప్పారు. అప్పుడు I was like totally clueless and remained in that. I personally somehow he's more connected to this topic, sir. So he wants someone to deliver this. So KGH assistant Venkatekrishna ani ma daggara ABCలో night చేస్తారు sir. Through him he contacted me and asked him whether I can do it. So the first thing was like when he only sent me the topic like that. So I was asking him like should I present this in some city branch topic or like that ISA city meet. I was asking him. Then he said, no sir, this is for the state conference in Vizag. What are you talking? So any other option is there? So then this background story has come, like this was his favorite topic and he wants someone to present it like that. So already one or two guys decided against presenting this, so I was the second or third option, sir. So I took it up, and then I was like totally clueless for around 1 month or so. Generally, in the first month after the topic being given to me in state conference, generally I gather the material and all, and then start the scrutinizing the material which is more relevant to the conference and all. That's how the sequence generally goes. But this year I was totally clueless what to present and all. Then I got some pressure algometry, some studies on pressure algometry. In one of the articles, some reference article was quoted in the text, like some guy has done a review article published in BSA in 2019, where he has got all the available, commercially available nociception measuring devices in one article, and he has analyzed them and how far the evidence goes and all. So that was like I struck gold with that article, and then with that base of the article I prepared it, and I was like very happy when this year when my friend Chandana being the chairperson of the talk and all, it went on well. So hopefully there's a more of I removed the title word current from the title for our group talk, because most of them hold no current relevance. Only in the future we may see the more clear role of Algesimeters in our anesthesia practice. So we'll move ahead. Are the slides moving, sir?
Move అవుతున్నాయి.
Yeah. Thank you, sir. Yeah. Coming to a brief introduction, the freedom of pain has long been defined as a basic human right. However, the incidence of moderate to severe acute postoperative pain has not changed for several decades and is still reported to be somewhere between 20% to 80%. This incidence is very much true. However, attempts we do, how much knowledge we gain, still we are lacking in many friends. Sometimes the gadgets are not available to perform, and sometimes the OT list being busy, we are not so focused on providing some nerve blocks and all. Sometimes we know we have to do, and somehow we are tied to an extent that we are not providing adequate analgesia. And this area of acute postoperative pain is being in the gray zone, and hopefully it will improve in the future. So problematically, pain is by its very nature subjective, per se non-existent, and hence unmeasurable in anesthetized subjects especially. So what we do, there is an alteration of hemodynamic things like heart rate shoots up or pressure shoots up. Then again, the $1 million question comes whether it is due to the decreased depth of anesthesia or due to the lack of proper analgesia. Then some pointers may fetch, like we with our clinical knowledge of studying the master's degree in anesthesiology or practicing for some years, we know some painful points in surgery. If at all we are focusing on that particular surgery only being in the OT, not roaming around 2 to 3 OTs, and identify the painful points like cutting open the dura and craniotomy, to mention one or two. then we give an analgesic bolus, or otherwise we practically cannot differentiate between why actually the hemodynamics are shooting up. So it's a very complicated thing to measure analgesia, especially in anesthesia subjects. So what can be monitored is nociception or a pathophysiological response to it. So brief history, even we are talking today as the technology not available to measure the pain, and we are not even optimistic of a near future like 5 or 10 years from here. But the attempts to make an algesimeter or to measure the pain have started around 83 years back. Maybe they have worked some 10 years before actually manufacturing it. So nearly 100 years back, only the attempts to measure the pain have started. So in 1940, these gentlemen have, from the Cornell University, have introduced the first algesimeter as a method for evaluating the effectiveness of analgesic medications. So they developed a pain scale called Hardy-Wolff-Goodell scale, named the scientist name, with 10 gradations or 10 levels, and those are termed doles, which is why the term dolorimeter as an synonym for algesimeter or analgesimeter, which is a device to quantify the pain. So in 1945, Cleveland's Gluzik had developed an algesimeter that actually measured pain in grams, just like how we buy or measure our groceries. So, and he has claimed his algesimeter to be 97% accurate somewhere when he developed it in 1945. Svensson et al. In 1997 has described the use of a CO2 laser or a contact thermode to heat the skin and elicit a pain response. These actually laser or a heating device, hot plate algesimeters, are actually much used in research studies on the experimental animals or rats like that. So Johnstone's algesimeter measures the sensitivity of skin to pain. Bova's algesimeter measures sensitivity over epigastrium. So coming to pressure algometry, which is the currently commercially available device, and we can even find it in India Mart, and we can get it. So also the publications are quite good number of publications are there for pressure algometry when compared to the following ones, which we are going to talk about, the monitoring systems integrated into the loop monitors. This pressure algometry is a separate device, and so how we measure? We measure preoperatively the pain sensitivity using the pressure grading, and again assess the postoperatively to how much pressure is actually getting the pain, and thereby after giving analgesic for how much pressure he is getting the pain and all. So it's more sort of a sequential study, just like how we measure what we can say like a procalcitonin or CRP like that, and see the responsiveness to the medication and all. The same way pressure algometry can be used sequentially in the pre-op and I mean to say in the perioperative period to measure the pain. So these are basically designed to quantify and document levels of tenderness via pressure pain threshold measurement and pain sensitivity via pressure pain tolerance measurements. So these are generally measured in muscles, fascia, joints, tendons, ligaments, and periosteum. The challenge in performing pressure algometry tests is to apply continuously ascending pressure at a constant rate at the patient's selected body site without having the possibility to monitor it in real time. So the biggest challenge, as you can see, is to first do the test correctly and replicate the same results post-operatively also. So this has been nullified to some extent with the advent of digital algometry, where you can, exactly how much pressure you are giving and all. But even then, the observer or the person who tests or performs the pressure algometry, it's highly dependent on him. So you and me both do the pressure algometry on the same patient. It's highly possible that we both give the different results. So this is the device, Wagner FPX. So this company device is available in the India Mart. Somewhere it's starting from around $295 to $895 on the could see in the American currency, but these are commercial available and deliverable to India also. And coming to few studies, this study is done by or Ganga Hospital, Coimbatore, but a team of orthopedicians, not a pain specialist or anesthesiologist. So this is a positive study for pressure algometry. Basically, they observed the depression, anxiety scores, and VAS scores post-operatively and all. So they noted a lower algometry levels corresponding with the higher depression and stress scale. You see a lower algometry means at low pressure you are getting the pain to the patient. So obviously his depression anxiety scale will be higher, and they correlated with the lower algometry. Also, low algometry score correlated with a higher postoperative VAS score, increased analgesic requirement, opioid utilization, delay in achieving optimum range of movements, and independent ambulation. So this is another study where it's a sort of neutral or more to the negative side for pressure algometry. There are studies both contradicting and supporting its use. As I said earlier, it's one of the most widely studied nociception measuring device. So these people have in Singapore University, they have studied in knee replacement patients. They have studied around 243 patients, and they assessed the response rate at 6 to 12 months. Is the long-term study. And they did not find any significant association of the preoperative pain measurement translating to the postoperative satisfaction or the pain assessment. So this is the article I spoke about at the beginning of the class. This gentleman named Thomas Ledowski has reviewed all the available, commercially available monitoring solutions where they have integrated into the monitors like multi-parameters, where just like we get an ECG and SpO2, you get the pain index too. So based on these monitoring principles, actually they are divided into, he has studied the 7 existing commercial solutions. So they are divided based on these monitoring principles into single parameter when they're using only single parameter, and 2 parameter scores and multi-parameter scores. So first we will discuss a single parameter score. It's just like our fluid 4-to-1 rule. So 4 scores are single parameter scores, 2 scores are 2 parameter, and only one score is there which uses multiple parameters. So this is the first one, Analgesia nociception index. So it is a 0 to 100 dimensional score, which is calculated from the area under curve of heart rate variability. So higher ANA values are thought to represent higher parasympathetic activity and possibly less pain or nociception. So you need to have a higher ANA value to achieve adequate analgesia in the intraoperative period. So in semi-conscious patient, again, ANA, as it looks over the heart rate variability, it's influenced by the emotions and other confounders. So it's less useful or has negligible value in awake patients and semi-conscious patients. So it's best utilized or used in general anesthesia. So ANA of more than 50 has shown a higher negative predictive value for the absence of acute postoperative pain and pain in the ICU. This particular scoring system, ANA, has more clinical relevance and negative predictive value. So if it is high, generally the incidence of acute postoperative pain is less. But coming to sensitivity, like it has more specificity than sensitivity if you talk about in the statistical language. So studies about the use of ANA to predict intraoperative hemodynamic changes and about the ANA monitoring of intraoperative nociception are overall inconclusive. So the glitch about all these latest monitoring things are they have no large RCTs at current to support their use and bring them from the bench to bed. So it may take few more years, maybe 5 to 10 years more, to establish their role and the monitors to get integrated with them, and also the costs to come down so that we can use in our regular day-to-day anesthesia practice. So this is a very good study published in 2013 by Boselli et al. So they have this is a one big positive study evaluating 200 patients, and they have found good correlation of high ANA scores with the less postoperative pain. But unfortunately, this is the only one large RCT which is supporting its use, and remaining or either inconclusive or moderately negative studies. So coming to skin conductance, this is known as This is based on galvanic skin conductance. It is the same principle which is used in lie detector, which is why I have placed that image. All the Telugu people can correlate with that iconic comedy scene from the Super movie where it's based on lie detector. So it's the same principle used for measuring the nociception. So NFSC refers to number of fluctuations in skin conductance. A more than 0.2 value may correlate with a severe postoperative pain and possibly also intraoperative nociception. However, many confounders influence the skin conductance in awake subjects. Again, this is better used in anesthesia, general anesthesia subjects. So during anesthesia, again, skin conductance appears to be a relatively crude measure. Unfortunately, this, especially the skin conductance, has got the least evidence among all the 7 parameters we will discuss now. But again, surprisingly, this skin conductance has been included in the only multi-para monitor available, null index, which we'll be speaking as the last one. So this skin conductance is more sort of a smoke detector. They compare it to a smoke detector because, as we know, a smoke detector detects if there is sufficient amount of smoke to cause the alarm to trigger. So in the same way, the stress level or nociception should be significant enough to measure in the skin conductance monitor. So it's being referred to as a smoke detector type of monitoring device. So coming to pupillometric assessment, we all know we dilate our pupils to pain. So pupillometric measurement has shown some promising results, such as reduction persistent postoperative pain. I mean, like it correlated with the pain scores and all. However, the method is influenced by several significant confounders like opioids, and all studies available to date are relatively small. Hence, there is a high risk of such investigations being underpowered for endpoints with a relatively low event rate, that is prevalence of persistent pain. Although the method appears more complex to use and implementation in the ICU has been reported, Wildemich and colleagues described the relatively easy implementation of the method in ICU, but they also concluded that further scientific evaluation was required to use it on a regular basis in our ICUs. So at present, no firm conclusions can be drawn about the clinical value because of the lack of large-scale RCTs. So this is the Algiscan device for the pupillometric assessment. Then coming to NFR threshold, I mean to say nociception flexion reflex. So this is based on the electromyographic activity. So the leads are placed at the sural nerve, and another receptor thing is placed at the biceps femoris. So we trigger the ipsilateral sural nerve and note the activity at the biceps femoris muscle. So again, its relative independence from various confounders like a sympathovagal may be a significant benefit, but again, limitations being a more complex setup needing for this NFR threshold and problems with accessing a patient's leg during surgery. You have to bear with the surgeon tantrums using up a leg completely. So however, studies investigating the method in the perioperative context are extremely limited, and this is NFR threshold is more of used in the research methods, and the clinical use is yet to be established. So coming to 2 parameter scores, surgical pleth index, this in a GE monitor. So it's same 0 to 100 score, and the GE recommended range for intraoperative SPI is less than 50. So the SPI and the null we are going to discuss, they have to be low, and it has to be high. So the method is unique in so far that it does not require any additional consumables but the use of a GE anesthesia monitor. So SPI has been widely studied perioperatively and is not considered useful in awake subjects. The clinical relevance of the described benefits remain to be further examined. So QNOX, QCon monitor. So this is again a wonderful monitor where they measure separately. QCon refers to consciousness, and NOx refers to noxious stimuli. That particular score measures the pain depth of anesthesia, and QCon measures the depth of anesthesia. So it's based on both EEG and EMG based dimensionless proprietary score. And according to the manufacturer, a QNOX of less than 40, again, this also have to be low. So only the ANA needs to be high. The QNOX less than 40 signifies a very low likelihood, 40 to 60 a low likelihood, and more than 60 a higher likelihood of response to an oxygen. So a study investigating 140 patients mainly found that QNOX and QCon proposed to reflect the level of consciousness. These scores were not identical and responded to different stimuli at different time points, possibly reflecting the two independent dimensions, anesthesia and analgesia. So this article is published in 2017. So overall, QNOX represents an interesting alternative to most other monitors for the assessment of nociception, as it does not rely on measure of peripheral or autonomic activity. And this may render the score more robust against the influence of cardiovascular medications and comorbidities. However, inventors caution that neuromuscular blocking agents were likely to distort the score because of its use of EMG signals. So this is the QNOX monitor where QNOX and QCon are displayed separately. So coming to the only multi-parameter score, null index, to date, this may be the only commercially available true multi-parameter nociception pain score. Like ANA and SP, it's a dimensionless score of 0 to 100 calculated via a proprietary algorithm based on 4 sensors: photoplethysmography, galvanic skin response, temperature, and accelerometer. All sensors are implemented into a finger clip, which is a highlight striking point of this particular monitor. So they are integrated into a finger clip similar to a SpO2 probe, and hence similar, very easy to use. So Martini and colleagues suggested a null of 10 to 25 as being the most appropriate for the maintenance of analgesia during general anesthesia. So this is the article published in 2015, and there is a supporting article the coming year in 2016 where the study, a second study was confirmed the stronger reaction of NYL to intraoperative noxious stimuli. So this is how it looks like, just like our SpO2 probe, and you get the index in the monitor. So to conclude, monitoring of nociception is a relatively new science. However, with the overarching goal of more automated anesthesia in mind, monitoring analgesia has become increasingly desirable. Within the past decade, several monitoring solutions have been commercialized. The most available monitors represent single to 2 parameter scores, with only one attempting a multi-parameter approach. All but one of these devices, that is QNOX, utilize the assessment of autonomic tone. Although all devices appear to reflect intraoperative stimuli slightly better than the traditionally used parameters, such as BP or heart rate to date, none has shown a convincing and clinically relevant benefit for its routine use. However, quantifying nociception or analgesia remains the holy grail in anesthesia monitoring, as it not only promises to reduce the incidence of severe postoperative pain significantly, but also the incidence of opioid-related side effects. So to conclude, where in a country where we are finding hard to convince the hospital management to get ETCO2 monitors to get instilled in all our OTs, so it's still a far-fetched dream to have an analgesia monitors in our armamentarium, but as most of our dreams come true with hard work and availability of technology, maybe in the coming decade, like the freshly passed postgraduates like Vamsi or those who are doing Santosh can use it in coming 10 to 20 years, and they remember me talking about all this nonsense around 10 to 15 years back. So thank you so much. Thank you for the patient hearing.
So మనకు ఏ విధంగా మనం దీన్ని రెగ్యులర్ గా వాడొచ్చు శ్రీకాంత్?
సార్ ఆల్గోమీటర్ ఒకటి వాడచ్చు సార్ డెఫినెట్ గా కమర్షియల్, బట్ అగైన్ దట్ ఆల్సో కాస్ట్ అరౌండ్ 30,000 లైక్ దట్ ప్రెజర్ ఆల్గోమీటర్, అండ్ అగైన్ హైలీ observer variability and all, and monitors have still to come, so it's long way to go. I think they are available in European market. I think I have to check with them, but again it will take some time for us to at present what the best we can do is more awareness of need for acute pain service. most of the times we neglect this part very much because of the busy schedule of the OTs, or sometimes the surgeon asks us to give the anesthesia fast and all. We are obliged to not to give epidurals or not to give plain blocks. Hardly they take 5 minutes if you're good enough with your interventions and all. So I used to say we have a general surgeon, a cousin of our Arvind, Dr. Ashok. He used to say, come on, come on, come on, come on. I used to say, you sit for 5 minutes, relax, have coffee, I will place the epidural and give the case to you. So like that, if we can convince them, it can happen. Most of the time we,
Okay.
again,
That-
the finances, sir.
Financial and comfort ఉంటుందా?
Sir, definitely, sir. They say finances, but again, they will keep all sort of analgesic medications and all. Again, if we give a TAD or QAD dosing of paracetamol and some other additional IV, it will cost nearly the same, sir. And again, they will not think about the suture materials, cost of suture materials and all they're using. And this is also, first of all, I think both of us are working for the same patient.
Suture
The
material
concept
ఏంటి
of-
నాకు అర్థం అవ్వలేదు.
Sir?
Sure material ఏంటి అన్నారు?
Are
Sir, in terms of cost, sir.
cost, sir.
Okay.
Thank you, Shrikant. It's a nice talk. But do you have any studies correlating between that visual analog or whatever we do as per the patient's rating scale with the algometers?
Yes, ma'am. That's the first study I have mentioned that done by our Coimbatore Ganga Hospital team of orthopedicians, ma'am. That's a very good positive study where they have studied in knee arthroplasties, madam. Around like 175 patients they have studied, and they have not only with the VAS course, they have measured in terms of a depression they have depression anxiety score they measured, the degree of ambulation, the postoperative VAS course, all these actually very well correlated with the pressure algometry. But there are positive and negative studies too. But that study particularly I kept because it's from India and a hospital we all know. There a team of orthopedicians have done that study.
Yeah, it's good. Like actually, sir, Monster Care Hospital daily of a patient ఉంటుంది sir, PKR అన్ని. I think we have to use this.
No, definitely గా, బట్ అన్ని ఆరోగ్యశ్రీ కేసులు ఎక్కువ ఉంటాయి కదమ్మా. యాక్చువల్ చెప్పాలంటే మెడికల్ లో ఎక్కువ ఉంటాయి, వాళ్ళకి చెప్పి చేయించాలి. మెడికల్ చెప్తే అవుతుంది.
అది చేసి మనం ఒక స్టడీ చేస్తే then we can say that the analgesic requirement is less, and then we have to say that the more patient comfort and whatever, like all hormonal changes, more of the stress related hormone cells level reduced, all these things we can show, sir.
ఆ లెవెల్స్ మానిటర్ చేయాలి కదా.
మళ్ళీ చెయ్యాలి సార్, మళ్ళీ కొన్ని అయినా చెయ్యాలి కదా సార్. అప్పుడే మన we can show that it is useful. Because diabetic patients.
Do you remember I asked you to do the test in GVP? Because of the cost. Last time ఒక టెస్ట్ ఎంత అని అడిగాను కదా మీ దగ్గర జీవీపీలో. మంజుల వాయిస్ వినపడలేదు మంజుల. వాట్ అబౌట్ ఆంకాలజీ పేషెంట్స్ కి ఇది బాగా పనికొస్తుందా శ్రీకాంత్?
But again, we can actually monitor. It's like a serial marker, sir. When coming to pressure algometry, it's more like a serial marker. We can use it and we can assess the effectiveness of the analgesic medication and all we are giving. So at the time, if we say at the pain points and all, if he's getting pain with some around 10 centimeters square pressure like that, and again after giving analgesia, if he's tolerating up to 25 or 30, that can show on us pressure algometry the same concepts. ఆ రోజు ఆన్ ద డే ఆఫ్ కాన్ఫరెన్స్ మన చైతన్య బాగా సివియర్ గా ర్యాగింగ్ చేసింది సార్ నన్ను. అండ్ షీ ఆస్క్డ్ వెరీ like a beautiful question, I can say. So she asked like if that null index or some other nociception score, it shows the patient is not having pain, like a null of less score, less null index, and the patient is complaining pain. What do you do? So I told her to speak to the manufacturers. No, but evidently, like all the machines and all, we obviously treat the patient and manage them clinically. Machine errors can occur definitely, but
Chaitanya is in the group.
చైతన్య ఆడేసుకుంది సార్. ఆ రోజు నన్నే కాదు మిగిలిన ఇద్దరు స్పీకర్లను కూడా ఆడేసుకుంది అక్కడ. నేను ఇంకా కొంచెం ఎలియన్ టాపిక్ అవడం వల్ల తక్కువగా హింసించబడ్డాను.
Sir, good morning, sir. Actually, that disconnected because of the zoo area, sir.
వాయిస్ అనబడలేదు.
No. Actually, that zoo area, no, the signal will be disconnected.
Yes.
Mohan, sir.
Yeah.
Sir, actually, I called you back, sir. You did not respond that day.
Yeah.
I will call you, sir, after some time.
Yeah. Anybody else?
Oh, sir, one request.
Yes.
Sir, because last time when we discussed regarding some presentation on anaphylaxis in the perioperative period, I think all of us can put their experience in WhatsApp and forward it to me, and then we can write an article on that.
Yeah, you are taking care of the CPR anaphylaxis, no?
Sir, we will just write it our experience, and then we will publish it somewhere in any of the articles that can be taken as a meta-analysis or something like later on.
Yeah.
I think so. Like from everywhere, everybody was discussing regarding the same thing. So can everybody post it to me?
Yeah, sure.
గ్రూప్ లో ఒకసారి పెట్టాను మేడం, అంటే ఇక్కడ తక్కువ మంది ఉన్నారు కదా, సో దట్
మొత్తం గ్రూప్ లో పెట్టామా?
Okay, sir. Okay, sir.
And next week, again, a very interesting topic by our Kiran. So he will be talking about our stuck epidural catheters, stuck endotracheal tubes, and all. What if we get stuck during our anesthesia or post our anesthesia? That's quite a good, interesting topic. So we'll hear from him next Friday.
And
Hello.
next Thursday, there's a physical meeting planning for teaching of critical care. Rani madam, just 1 second. I'm going to leave. So we are going to take the physical meeting, and I asked David where to conduct and what time, because he was telling 7:30 to 8:30, because whoever is interested, they can really come and do it. So that is a plan. So don't know where and all. I asked David to conduct
Okay.
only for the next class. Thank you, madam. మీరు చెప్పండి రాణి మేడం.
హలో శ్రీకాంత్
మేడం.
సారీ నేను మధ్యలో మిస్ అయ్యాను, బట్ వండరింగ్ లైక్ అల్జెసిమీటర్ అనేది టు నో ద థ్రెషోల్డ్ ఆఫ్ పెయిన్ యూ సెడ్, రైట్?
Yes, madam.
So if it is to know the threshold of pain, actual పెయిన్ కిల్లర్స్ ఇచ్చినప్పుడు యూజ్ చేసినప్పుడు పెయిన్ అసెస్మెంట్ కి యూజ్ చేయాలా, లేకపోతే టు నో ద పెయిన్ థ్రెషోల్డ్ ఆఫ్ ఎ పర్సన్ even otherwise use చేయొచ్చా?
These are two completely different things we spoke about even in the presentation, madam. Pressure algometry works on that principle, madam, to know the threshold of pain and all. So pressure algometry, how we do, we apply pressure to some particular selected points and all before the surgery, and post surgery we again measure the sensitivity of the pain. And then from there again, the effectiveness and analgesic medications and all we can measure. And most of these scores which are integrated into the monitors like our SpO2 or ECG, they actually provide a real-time value of nociception level. So how the patient is feeling the pain and all. So that is the target of all these closed loop monitoring systems. Those two are completely different. This is again observer dependent, or I mean, like the person who tests it depends on him. But those monitors are actually independent of and they give a value like just like how desaturation occurs. We try to correct the oxygen level and all. So the same way we know the pain felt by the patient. So,
And is
Good
it
morning,
correlating
sir.
with the hemodynamics?
they say, madam, the studies say that, but again, the large scale RCTs are lacking at now. They are very well correlating with the patient's level of pain and hemodynamics and all. But again, most of the monitors also, in those 7 also somewhere like around 4 monitors, they take the cardiac autonomic tone also as one of the parameter or the sole parameter.
Yeah, because pain is a subjective parameter. Maybe that's why not so many studies were done. Once when the patient is awake or conscious, they can tell about their own pain. But
Yes.
maybe this is more valid when the patients are like people who can't express or who can't tell about the pain, but need to have big procedures and painful procedures. Maybe for them, maybe it is more useful, right?
Especially these are devised for the patients under general anesthesia. Most of the latest ones and the monitors and all, they are designed for general anesthesia only, madam.
Oh, okay. So for during procedure, during anesthesia use cheyadanikeena?
Yes, ma'am. Yes, ma'am.
Not so
Uh,
something like
Again,
this.
awake again, there are some confounders and they will alter the scores and all. They're more useful in general. Most of them. I mean, not all, but
Okay.
Chaitanya.
Okay. Thank
Yeah,
you.
good morning, sir.
Good
Actually, I didn't drag you. This was exactly my point. If Rani madam cheppar kada, that was exactly my point. If the patient is unconscious or semi-conscious in the OT or ICU, these are fantastic. But when the patient is awake and patient complains of pain, indefinite of this meters and all, patient has pain, we treat the pain. This is quite subjective. That was only my point.
The most of these were designed to measure the pain during anesthesia only because they can't express.
Yes.
Also, maybe in
Yes,
period.
Yeah. And second thing is like, yes, treating acute pain is very, very important. And we to yes, surgeons, not always they are willing for us to place a epidural or do a nerve blocks and all. They say it takes time. Maybe అంటే మనకే కాకుండా వాళ్ళకి కూడా అవేర్నెస్ తీసుకురావాలేమో దట్ acute why treating acute pain is important, what happens, the peripheral sensitization and central sensitization, patient lands up in chronic pain and all. ఇవన్నీ మనం వాళ్ళకి కూడా అంటే అర్థమయ్యేలాగా చెప్తే maybe that is when this all scenario changes. And last time Balvenkat sir ni kalsinappudu, what he was saying is, why are you people not having acute pain,
that's what Chakra sir
acute pain care మీ ఎందుకు లేదు అని చెప్పి, because that is what is most important, because once we treat that is when actually even the surgeries help.
Acute pain లేదు అంటే ఏంటమ్మా?
TKR done and sir,
acute pain లేదు అంటే ఏంటి?
acute pain
like they were talking about
acute pain
department.
teams అంటే
APS. Chaitanya, watch.
Otherwise, patient gets done TKR, the implant is placed beautifully, the patient lands up in pain, and osteoarthritis ni treat chesi patient chronic pain loki vellipotaru. So I think maybe that is more important.
ఏంటో మీ ఇద్దరు పెయిన్ స్పెషలిస్ట్ కి అన్ని అర్థమవుతాయి, మాకు అర్థం అవ్వవు.
ఏలేదు సార్, పెయిన్ క్లినిక్ లాగే అక్యూట్ పెయిన్ సర్వీస్ ఏపీఎస్ క్లినిక్స్ పెట్టాలని అదే ఆ రోజు యాక్చువల్ గా స్టేజ్ మీద లైక్ చక్రరావు సార్ ఆల్సో ఆస్ ద సేమ్ థింగ్ సార్ టు ద నీడ్ ఫర్ ఎస్టాబ్లిషింగ్ ఏపీఎస్ క్లినిక్స్ ఇన్ ఆల్ ద బిగ్ హాస్పిటల్స్ అండ్ wherever they are feasible. Okay, sir. Sure. Thank you, Chaitanya, for again coming to class and patiently hearing all that again. Sir, next week we are in for another interesting topic. Kiran, let's see you all then. And after a long gap, pretty much excited for a physical meeting on Thursday. Hope most of us meet there. Okay, sir. We'll wind up, sir.
Okay, thank you. Thank you, Shrikant.
Okay, sir. Thank you. Sir.
Thank you, Shrikant.
Thank you, sir. Thank you, Manjula madam.